we good? Okay. All right, so thank you today for joining me for this discussion on multimodality imaging in cardio-oncology. I really want to thank all my colleagues and friends and mentors here at Houston Methodist, as they have a tremendous impact on my career and where I am at right now, along with continuing work amongst the institution. So thanks to Dr. Deepan Shah for opening the doors and helping with a lot of our patient care, getting access to CMR. So when we talk about multimodality imaging in cardio-oncology, it's a very interesting, novel field. It's very unique, and you guys probably will be one of the first people to hear about such a whirlwind of imaging modalities and how they relate to these patients. This is the first patient actually I saw in clinic up here, first echo I've seen. This is the second CT that I had to do as part of a complex PCI planning with an anomalous RCA. And then this is my third CMR with constrictive pericarditis in a cancer patient. So without further ado, no disclosures. When we talk about this field, we need to kind of define what cardio-oncology is. What are the key roles and complications that cancer patients have, along with the role of imaging and where we stand as multimodality imagers and future directions. So in the field of cardio-oncology, this is a new field. It's a very important field to recognize as cancer is growing at a tremendous rate. It's an interdisciplinary field within the that focuses on the cardiovascular health of cancer patients, and it requires special expertise in preventing, recognizing CV complications related to cancer or the therapies that are being used for it. Are we okay? Okay. So we meet these patients at different time points. Usually we want to see them at baseline. We follow them during their acute phases where the majority of the issues tend to arise. And as these therapies are getting better, the survivalship is increasing. So the aim of us cardio-oncologists in this field is actually to limit interruptions in cancer therapies because of cardiovascular effects. So let's hone in on this part. The primary disease pathology is cancer, and cardiovascular adverse events can arise. But if we don't treat the beast, then cancer is going to survive. So, and the outcomes are really poor from a cardiovascular and a cancer perspective. So we really need to risk stratify our patients very early on from a cardiovascular health and fitness. A 40-year-old female with breast cancer is very different than a 70-year-old male with ischemic cardiomyopathy with lung cancer when we see them in the clinic. Who's going to do worse? Obviously the lateral. So recognizing who's low risk and high risk is going to guide a lot of how we follow these patients and what we do for them. When we talk about cardiotoxicities in this field, we talk about direct cardiotoxicities. Those are what you commonly think of, the doxorubicin-based agents and the radiotherapies. However, there are a lot of cardiovascular adverse events in the field of immunotherapy and targeted therapies that are on the rise. And then there is all the background cardiovascular comorbidities that these patients have. So cancer and heart disease have a lot of baseline characteristics: smoking, obesity, you name it, inactivity, increase the risk of cancer and CVD. So there's a lot of shared common pathways between the two. So when we talk about the baseline assessment for these patients, it's directed at taking a very thorough cardiovascular history at the onset, looking at what, in collaboration with the oncologist, what type of cancer therapies they're going to be on, and very importantly, recognizing if they've been previously treated for cancers, because it really has tremendous roles in how you manage them moving forward. From an imaging and a biomarker perspective, just like any other cardio clinic visits, you do the biomarkers, but we always include troponins and BMPs because these are going to be used in the guidelines moving forward as to how to serially follow them and monitor them. And the role of echocardiography is key in this patient population. So the gamut of cardiovascular toxicities ranges along every single cardiovascular system, from the electrical conduction system to the muscle abnormalities, arterial venous thrombosis, systemic hypertension, pulmonary hypertension, valve disease, and pericardial disease. And we'll go through this in a case-based presentation. So when you think of cardio-oncology, you probably think of the cardiomyopathies. That's all I knew about this field when I first started into it. And we talk about these definitions of symptomatic cancer therapy-related cardiovascular toxicities. These are actually easy, the easiest ones to recognize. These are the patients that come into clinic or end up in the hospital with heart failure. And they're classified according to the recent consensus guidelines. Finally, we have some guidelines in this novice field that came to us from Europe and published in November of 2023, 2022, if anybody is interested to review them. They're pretty good, but they're on a spectrum from mild to very severe. Those are the patients that have heart failure that come into clinic. You may need to up-titrate medications. That becomes on the moderate range. Severe are the ones you're sending to the ER. And then there are patients that get admitted to the CCU and ICUs with inotropic support, mechanical support, in some cases would require transplantation. The asymptomatic variant is a lot of what we're going to focus on here at this beginning of the talk, because it's really important and it's heavily dependent on cardiovascular imaging. The asymptomatic cancer therapy-related cardiovascular toxicities are pretty much an echo-based diagnosis. So in the mild range, those are the new changes in LVEF to an EF greater than 50%, still low normal, with a new relative decline in GLS greater than 15%, and or a rise in biomarkers. And the biomarker ranges are kind of stark, with a troponin at the upper limits of 99th percentile, BNP above 35, or a pro-BNP above 125. But then they throw a caveat, like if it's a change from baseline, so go figure. In the moderate range, those are the patients who have a decline more than 10% to an LVEF in the mild range, the 40 to 49%, or a reduction less than that 10% cutoff to an EF between the 40-49% range with GLS abnormalities and a rise in biomarkers. The severe range is when the EF drops less than 40. So if you take anything from this talk, you really need a good echo, a really, really good echo. In our lab, and the consensus statement and all cardio-oncologists are moving towards a 3D LVEF. So the majority of our patients are getting 3D LVEFs, and you report, just like CMR, a single value LVEF, because this is how you monitor it over time. If you're looking for a percentage point, it's very difficult when you're giving a 5% range. A 50 to 55 is not going to cut it. If we're unable to do a 3D LVEF, the second recommendation, all our reports have 3D and 2D Simpsons by plane EFs, single range. We use echo contrast in order to improve the images. And in those cases where you do not have that ability to report it, an MRI becomes key, and that becomes your mode of modality to establish EF assessment and follow these patients. So this table is quite challenging. It kind of tells us all the cardiotoxic effects that may arise with these classes of medications, and the rates of approval of these anti-cancer therapies is at a very stark rate. So we're faced to learn new mechanisms on a regular basis, and keeping up with the new medication terminology is even more challenging. But if you look at the cardiomyopathy part here of this situation, the anthracycline-based agents, along with the HER2-targeted therapies that we commonly think of in cardiomyopathies with breast cancer patients, are some of the ones that pop up. But the new frontier in cancer therapies is directed at using the immune system. That's the immunotherapies and the CAR T-cell therapies that are also heavily associated with these cardiomyopathies and a lot of other adverse events. We'll touch upon these via case presentations. This is overwhelming even to look at, but these are the type of things that we're faced with on a regular basis to learning these therapies and treating them. So when we talk about the different monitoring, especially echocardiographic assessment for these patients, the consensus guidelines now recommend also risk stratifying the patients. The low risk and intermediate risk patients undergoing anthracycline-guided therapies are very different than those high-risk patients. Usually we advocate for a baseline echo and then post-treatment echo at 12 months. And the reason we'll get to that is, we'll touch upon it in a little bit, but we do not want to interrupt chemo or their cancer therapy. The high-risk patients are getting over-imaged, usually every other cycle, and then thereafter, after the 6th cycle, that's usually the conclusion of their anthracycline therapy at 3 and then 12 months. The HER2 therapies, echoes are often, more oftenly ordered. These patients are either in the hospital admitted due to the complications of their cancer, or in a clinic visit and getting an echo. So although the guidelines recommend every 3 months, unfortunately these patients get over-imaged and it creates a lot of havoc. As we think of the other aspect of the echo assessment, the strain assessment in cardio-oncology is quite important, as it is an early marker for heart dysfunction. The strain, as we know it, is a measure of deformation, the ability of the muscle to stretch and contract, providing a sensitive way to assess cardiac dysfunction before heart failure arises. So a lot of data is being put out there. A lot of the groups in cardio-oncology are just trying to put their data out there. One of the more robust trials here that was published is the SECOR trial, and this trial kind of risk stratified patients who were receiving anthracycline-based therapies, the doxorubicin-based agents. The predominant nature of those patients were metastatic breast cancer, to an LVEF guided strategy or an abnormal strain guided strategy. So they all started off with normal LVEFs, and over a year span, the patients who had a decline in LVEF versus those who got treated based on a decline in strain, okay, were followed over time. Cardioprotective agents were started for strain reduction by about 12%, and at the 1 year mark, they saw that the group that received so this is the patients that received the cardioprotective therapies, the GLS arm at 12 months had a less decline in LVEF at 2.9% compared to those who were started on cardioprotective therapies for an EF decline at around 9%. So that was the first end of the story. At 1 year, the strain-guided arm looked better. They didn't drop their EF as much. Then the group got followed for a 3-year period of time, and the data was published. And what we saw in this group at the 3-year mark, despite the cardioprotective therapies were used at a higher level in patients who were in the GLS-guided arm, the rates of cardiac dysfunctions and EF drops did not really change, in both arms. So this was pretty much a negative trial. The group itself started thinking of the MRI end of it, using future tracking strain imaging with CMR for these patient populations. And when they ran this trial, at 1 year, similar to the first trial, there may be just a little bit less decline with cardioprotective therapies in the strain-guided arm versus the LVEF-guided arm. So it's quite a complicated story, and you might hear it in my voice, like there's a little bit of hesitations. We in the cardio-oncology community at this point, we understand that the cardiomyopathy and strain abnormalities precede LVEF changes. However, what do we do clinically about this is a big question mark for us. We do not, again, the main role is you want to get those patients in the safest fashion to get through their cancer therapies without interrupting the chemotherapies. Otherwise, if we start interrupting therapies based on just imaging biomarkers, they might not get the best cancer care. So it's a complicated situation. The higher risk patients are the ones that the conversation with the oncologist becomes more robust, adjusting agents using liposomal-based anthracyclines or other cardioprotective agents. So this is the story of imaging in this cardiotoxic cardiomyopathy picture that we often look at. There's no MD Anderson talk without cardiac metastasis, and there's no greater role for probably a cardiovascular imager than looking at cardiac masses. I'm going to start this by saying that, there are a lot of schematics, there are a lot of papers published on cardiovascular tumors based on location. It might be this. Based on tissue characteristics, it's going to be that. I'm here to tell you that take everything with a grain of salt. We see it on a daily basis, and tumors, unfortunately, especially malignant tumors, do not behave. They never have, and they never will. So there's always an exception of the rule. Now, thinking about heart masses, the majority of them are benign, thankfully. 90% of them are benign. Malignant tumors are quite rare. Pseudotumors, those are the ones that when we talk about the thrombosis, cysts, or vegetations. When we look at primary benign tumors of the heart, myxomas they're the top of the list. Fibroelastomas and lipomas are next. The majority of myxomas are usually, 75% of them are left-sided, and here I am showing you a right-sided myxoma. So 75 of them are left-sided on echo arising from the fossa ovalis, heterogeneous enhancement with contrast. On CMR, it's said that they're iso-intense, but if you look here, there are regions of hyperintensity, hyper-intense T2, mild diffuse perfusion. However, this is nothing short of very high perfusion and heterogeneous LGE. This patient was referred to surgery, and she got a CCTA. And if you look at the posterior aspect of the RA, where there are extensive vascular networks, the surgeons were really hesitant at the time of taking her to the OR. They were thinking it may be an angiosarcoma. Thankfully, tissue diagnosis came back as just a very hypervascular myxoma. On CT, they tend to have calcifications when you see them on PET. They are usually not FDG avid or just minimal avidity. Fibroelastomas are the next most common benign masses that we see. They're usually on the valves, and here I am showing you an RVOT outflow tract MRI. The pulmonic valve is fine. The tricuspid valve is fine. This is a patient with prior history of cancer that we've been following. We saw a mobile mass on echocardiography. The CMR here shows this pedunculated mass, hypermobile features of fibroelastoma. She wanted it out. Whenever a patient has cancer, any new mass creates a lot of anxiety. We thought it was an overkill. She found a surgeon, she got it out. It was a fibroelastoma. So on CMR, iso-intense, homogeneous or absence LGE, they don't normally perfuse. They create, not because they probably don't perfuse, they could, but the reason is they're so hypermobile, they create a lot of defacement, and the perfusion imaging tends to be very difficult. On CT, we see low focal attenuation, and there's no PET uptake on these as well. So this is another case of a benign mass that was initially referred to us for concern for thrombus extension in a patient with leiomyomatosis peritonalis. These are tumors that we need to recognize, because oftentimes when we look at these tumors that arise from the IVC, oftentimes we only think of RCC as the primary IVC tumor. But these are the second tumors that usually arise from the IVC into the RA, RV, and across a pulmonic valve. So in masses, we always say CMR is probably the preferred method of assessment due to the superior tissue characterization. And I would say I agree with that 100%, with one exception, is hypermobile masses. So I remember when I was a fellow, Dr. Shah would say, do not image endocarditis with CMR, and it's very true. These are hypermobile masses. And even huge masses, like we saw in echocardiography with with this patient. The extent of hypermobility creates dephasement in the protons, and it can render these studies very difficult to interpret. So this was just a mass that was flopping all through the RA, from the RA to the PA, all throughout. We ended up taking the patient to the OR. I was in there, we saw it. They did an arteriotomy with a finger extraction. They pulled up the tumor. This came all the way. So this is an entire benign muscle tumor that tends to extend from the GU tract upwards into the IVC and invades in the heart. Tends to happen in females of reproductive age. There is some hormonal predilection increased with those on OCPs or prior surgical manipulation in the GU tract. Although they are benign, they can degenerate into leiomyosarcomas. So preferred treatment against surgery. There is some patients, the ones that only have localized tumors, do not want to go through surgery. They use progesterone or gonadotropin antagonists to target these. So now on the flavor of malignant tumors, again, rare. Metastases run the list here. Metastases are a lot more common than primary malignancies, thankfully. Primary cardiac malignancies are very, very rare, okay? Let's keep that in mind, and that's a good thing because the prognosis with them tends to be very terrible and poor. Metastases on echocardiographies tend to come in multiples. There's usually a pericardial effusion with intense uptake when we give echo contrast. On CMR, metastases tend to be hypointense and hyperintense on T2. The exception to this is melanoma. Melanin acts as a T1 shortening agent, similar to gadolinium. So melanoma patients have hyperintense T1 signals and hyperintense T2 signals. Now, when we talked about metastases to the heart, the most common things that metastasize are actually melanomas, followed by lung, breast, and thyroid cancers. And in this case, I think I published this when I was a fellow, okay? This patient had 2 primary masses that was iso-intense on T1, hyperintense on T2. We thought it was a malignancy, and when it was biopsied, it was a melanoma, okay? So it's also an exception to the rule. It's not hyperintense on T1. It was an amelanotic melanoma. So again, cancer doesn't really follow any guidelines or what the textbook should say. On CT, they tend to be hypodense, and on PET, the higher the SUV, usually we talked about SUVs above 4.95 being more malignant. So these we commonly feel comfortable with. So the higher the SUV on PET, the more likely it's malignant. So this is another patient that got referred to me from an outside hospital and to the oncologist same day. He was being treated elsewhere for a lymphoma that was responding everywhere except for a growing anterior mediastinal mass right by the main PA. So we referred this patient for a CMR, and on T1 imaging, it was mildly hyperintense, very hyperintense on T2-based imaging, and this is just the location of this mass. It's not invading into the main PA, but it's just hugging the wall. And when we look at the LGE and the perfusion of this mass, it took up a great deal of contrast with central necrosis. So in this field, I like to quote Dr. Nabi here. You're either right, you're either wrong, but you're never uncertain. You need to make up a diagnosis. You need to put, what your strongest impression in the CMR report. And so I had to come up with a report for this patient. So putting it in clinical context, a lymphoma that's improving elsewhere except for an enlarging mediastinal mass is of concern. Anything that involves the PA is a sarcoma, an angiosarcoma until proven otherwise. So that was the main differential and less likely lymphoma. I had to explain myself during interim board, but we went ahead and biopsied it, and it was an angiosarcoma, thankfully. So angiosarcomas look like cauliflowers, okay? The most common location based on the literature is right atrium, and these are the most common primary malignant tumors of the heart. But in this case, it was involving the main PA, and you always want to exclude it. Again, if you take anything from this mass talk, if a mass involves the main PA, angiosarcoma until proven otherwise. They're ISO to hyperintense on T1-based imaging, hyperintense on T2, very hyperintense on T2. Lymphomas tend to have some edema in them, but they're not as hyperintense usually on CMR. They diffuse quite starkly, and then they have usually central necrosis on CTs when you refer them, and very, very high SUVs. So moving from this, another patient population that we commonly see is carcinoid. I see carcinoid quite often in our patient population. This is a patient with systemic carcinoid, is having now worsening shortness of breath. Echo was ordered, and you see here normal tricuspid valves. The pulmonic valve is sitting up here. It looks relatively okay, but on a closer look within the RVOT tract, there is something prolapsing in here. And when we look at the color Doppler, there's slow acceleration, which correlates in this segment. Both CW and PW are about 1.7. So we referred the patient for a CMR for further evaluation of the valves and assessment of what this mass might be. So what we see here is a very large mass occupying the interventricular septum into the RVOT tract. Okay, it is hyper-intense on T2 signals and relatively iso-intense on T1 imaging. Anything that's this hyper-intense is concerning in combination with some LGE uptake. In this case, the patient went on to get a nuclear scan, which is the 68 dotate scan. It's a neurohormonal nuclear scan we perform to assess for neuroendocrine tumors. And here's the heart, it lights up. This is the tumor. This is actually carcinoid heart disease, metastasis of carcinoid heart disease without any valve involvement. So the largest series on these patients came from Mayo. They had a 14-year experience, very limited number of metastases. I think this is an entity that's under-recognized. They're often present in the RV. Trabeculations in RV walls is what we're finding, and often missed on echocardiography. The reason it's important to start looking for these is that there are now targeted therapies that can be directed in targeting these masses over time. So it's a field that we're looking at closer and we're interested in. So again, the commonality is what we normally see is the carcinoid valve disease, tricuspid, followed by pulmonic valve involvement. You guys all see it probably, the thickened, restricted leaflets, as you see here on this echo. But we need to start thinking beyond just valve disease with carcinoid. Pseudo tumors, I'm just going to focus on the first part of it, which is the thromboses. Cysts and vegetations. For vegetations, it's echo, echo, then echo, with one exception. Prosthetic valves, there is a very important role for PET imaging for assessment of endocarditis there. Cysts are commonly delineated on echoes, very common features on CTs. They're very low attenuating. But a great deal of problems we see in the realm of cardio-oncology is thrombosis. So these patients have prothrombotic diseases that allow for them to clot, such as pancreatic cancers and GBMs. They clot. The moment you introduce a catheter, the amount of thrombosis you see on any catheter kind of gives it away. But they clot in all different aspects of orifices within the heart. The most common presentation of thrombosis we see is what I'm describing here. We see this probably on a daily basis in our echocardiography lab. This right atrial lesions that are referred then to CMR. So this is probably the most common referral to CMR at MD Anderson, which is a right atrial mass that involves the posterior inferior RA wall. And they tend to be in a region right at the inferior tip of the RA. What these masses are actually catheter-based thrombosis. They happen to be on the wall that is directly across from where the ports dump the chemo. They cause a lot of scarring within the LA wall, and that just creates for an inflamed milieu and thrombosis. So if you see this once, you will recognize it. They don't perfuse on CMR. We see them on echo on a daily basis. TI-based, TI-600-based imaging, you see these large clots within the heart. So on echocardiography, we know what thrombi normally look like. Yes, they're in aconnected areas or low flow orifices, but in cancer patients, that's not usually what we see. We see thromboses in various areas, especially with the advent of immunotherapies now and certain TKIs. The patients clot in hyperdynamic ventricles, they clot in LVOT, RVOTs, and aortas. So it kind of defies that logic. CT has a tremendous role. We use it often for evaluations of left atrial appendage. We always have to do a delayed phase. You don't see filling on early or delayed phase, and no FDG uptake, obviously, on PET. So as I mentioned, thrombosis can happen anywhere, not only in akinetic or low flow segments. This is a patient that was just imaged by PET imaging a couple of days ago, and they called and said, hey, we see a filling defect. The patient went through some immunotherapy regimen that we don't know what really the immunotherapy is. They're on a clinical trial, and they asked me to review. We did a CTA, and there's this thrombus within the aorta that was relatively new within a month. The patient was already on anticoagulation for a prior history of PE, so they clot often. The incidence of VTEs with immunotherapies are quite high, about 10% at 12 years, at 12 months, and the arterial thromboembolism story is yet to unfold. We suspect that these rates are much higher than what's described. So when we talk about masses, the rare SAM features, we do try to use a multimodality approach. Effusions are very bad. Anytime there's an effusion, any cancer patient, active prior history, you gotta worry. They're not what they are, they're never benign in my mind. So you have to look further. Multiple lesions tend to be malignant. Any masses that are irregular in border or they invade borders tend to be bad. So the next frontier, I kind of alluded to immunotherapy. This is a case in point, a patient with gastric adenoma on ipilimumab and nivolumab. All these mAbs are immunotherapies. So they come into the ER here with shortness of breath and fatigue, some muscle weakness. We get consulted for very elevated troponins. Troponin T, about 1,400, troponin I, 8,000, CK, CKMB, a closer scan of the ECG here, the patient's in complete heart block. We take them to the cath lab, coronaries are clean, EF is fine. We do a biopsy because this is how they normally present. EF is preserved, very, very high troponin, and the biopsy came back as immune checkpoint inhibitor myocarditis. So if you take anything from my talk today, probably this. We need to start recognizing it. Immunotherapy is on the rise. They're currently approved for more than 20 cancers. They were initially started with melanomas, but now the majority of cancers are having a form of immunotherapy, guided-based therapy to treat them. They're revolutionary. They're really improving the field of cancer, but effectively, how they act is they reactivate our natural T cell killer cells. So cancer cells evade the immune system by presenting antigens such as PD-1, and when this connection has happened, our immune system thinks they're normal because the majority of our cells present this as a check, a normal check that, hey, I'm fine, this is a healthy cell, but the tumor cells learn that this is one of the mechanisms that T cells kills them. We block these with immunotherapies. The moment this mechanism is blocked, the T cells get reactivated. Unfortunately, as we do this, a lot of healthy cells get affected, and so we have immune adverse events spanning every single tissue organism. The most common one is usually colitis and pneumonitis, and they span the gamut of every organ system. Thankfully, myocarditis is not one of the more common one, but the mortality is extremely, extremely high. It's under-recognized, and now with the advent of this push for immunotherapy to be as a mainstream part of the anti-cancer treatments, I'd say in 2020 they published that 22% of cancer patients are receiving immunotherapy. As we see it, more than a third of our patients now are on immunotherapy, and it's likely headed to a much higher rate. So this is a problem for all of us to start recognizing. Cardiovascular toxicities can either be direct or indirectly. It spans a gamut of arrhythmias, myocarditis, heart failure, pericarditis, and as I showed you earlier, clotting and thrombosis. Now there's an overlap syndrome. If you see a patient in the hospital that you're called for troponin elevations who has myasthenia-like symptoms, ptosis, or severe muscle weakness, you gotta check for this entity, because if untreated, the mortality rate is very high. It usually presents around 30 days from the initiation of these therapies, usually after the second dose of immunotherapies, and the majority within 3 months of initiation. When we talk about echocardiography and the role of strain imaging in this patient population, there's a tremendous wealth of data that's coming out that the majority of patients with ICI myocarditis, as I mentioned, have a preserved LVEF. However, if the strain starts dropping, these patients are going to have very adverse events. So even a reduction of 1% in GLS carries a 4-fold increase in MACE in a normal EF. So strain is proving to be one of the first things we are seeing as we follow these patients. Now the question of CMR, I wish was very simple, because CMR in myocarditis has a tremendous wealth of, in regular myocarditis, we have a great deal of information that now CMR is the first line imaging modality to recognize myocarditis. We have the modified Lake-Louise criteria looking at T1, T2 based agents. The T1 based agents are looking at fibrosis, and the ECV picture of it there with T1 based mapping techniques looks at the permeability and the fluid edema within the space. And then the question of the T2 edema imaging is very stark, and we have sensitivity and specificity upwards in the 80s. When we look at implementing the modified Lake-Louise criteria for ICI myocarditis, we fail. We fail miserably, especially early on. There's a very poor agreement between CMR and endomyocardial biopsies very early in the disease process. And this is a time-sensitive diagnosis. You want to catch it early and treat it early before the patient decompensates. Some of the data comes, our data is in agreement with this group's, Zhang's group. They had one of the largest studies that were published as well that showed a very poor association between CMR and endomyocardial biopsies. So as we know it, every patient with ICI myocarditis gets biopsied in our hospital early on. Just a case in point, this is a 67-year-old patient on ICIs presented with dyspnea and syncope. Day 1, we get consulted low troponins. Day 2, patient's getting worse, short of breath. The second troponin that day is very high at 2,700. Day 3, taken to the cath lab. Coronaries are normal, low normal EF, now with ocular ptosis. Clinically, this is what we see. CMR on day 4, by tissue characteristic, EF assessment, and scar edema, everything looked normal, okay? When the patient gets obviously treated, biopsy proven myocarditis, we re-image them at 21 days. For those of you astute in the audience with CMR, now you see a non-ischemic scarring pattern in the inferior wall that wasn't there. The tissue characteristics continue to be okay. So this is what we see really early on. We don't see any abnormalities. After several weeks, we do see scar, but this is, again, a time-sensitive diagnosis. We do not have time to wait for that. We looked at the question of PET imaging. So we ran this prospective trial last year, and we published it in JNC. We had 10 cases where we enrolled patients who we had suspected myocarditis clinically. We did a PET scan, a CMR, in the majority of cases, and a biopsy and all. And there was actually very poor agreement. It was very difficult to get PET scans on these patients because of the dietary prep, and a lot of them are getting steroids with all their chemotherapies. And so you want to hold all steroids before running the scan. So it proved to be very difficult. We're moving away from this. There's now newer agents looking at G68 radio tracer to assess for this. But again, we don't have a good non-invasive way to date to detect it. So the treatment is basically temporizing the immune system, and we have different ways and modulators. Again, please recognize it. We get patients coming from all different hospitals around the city, around the states, with this diagnosis, fulminant myocarditis. So now that you heard it, you probably will not miss it. We have a recent publication from our group, if anybody's interested in BMJ, that highlights the highlights of this. So it's a clinical and histopathological diagnosis at this point, and there's great value in it. We're going to move on to radiation heart disease. The majority of this comes to us from the Hiroshima survivals. That's when we started recognizing that radiation heart disease is a thing. In medical treatments back in the 70s, they saw a 7.2% increase in cardiovascular deaths in patients who were getting radiation therapies. And the question of what is driving this becomes a big question mark. And to date, we don't really truly know what is driving the mechanism, but the most agreeable theory is that radiation causes acute inflammation and across the vascular beds, extensive collagen deposition, and over time fibrosis. So how do these patients present acutely? They present like this patient usually. They present with arrhythmias and pericardial effusion. In this case, this is a patient who was referred to us with pericardial tamponade after receiving radiation and was short of breath. So anytime patients coming in following radiation, you have to think about pericardial disease if they're short of breath or chest pains. Again, acutely arrhythmias and pericardial disease. As we look at the 5-year mark, vascular aging, accelerated vascular aging, and now with the advent of CCTAs, we see it very beautifully, probably better than any other modality. We see the early scarring and the thinning within the lumen. Cardiomyopathies are a big problem. As this population grows, both diastolic, restrictive, constrictive physiology, and valvulopathy. It's dose dependent. Those who receive grades more than 30 are the ones that have a linear increase with valvular heart disease, and location matters, especially when we talk about the field of view that gets eradicated. Thankfully, radiation therapies now are proton-based and there's less scatter, so the coronaries are not getting as affected. But this is a patient that came to me probably 2 years ago when I first started there with history of Hodgkin's lymphoma, recurrent heart failure admissions, was told that she had untreatable valve disease, and she kind of was crying. I referred her to our valve team, and they talked to her extensively. She had stigmata of severe mitral stenosis as we know it, severe thickening within the aortomitral curtain, and severe calcification within the aortic valve. So after a lot of deliberation, one of the surgeons and her decided to move forward and take this patient to the OR, and she came to see me last week and she wanted to share her images. Now she's status posa cabbage with an SVG to the RCA. She has an AVR with an MVR. They did a commando procedure. They reconstructed. She's short of a heart transplant. They reconstructed all her mitral and aortic apparatus. It was a 10-hour surgery. She's doing well. But this is pretty much end-stage valvular disease in radiation patients. When we talk about these patients, the pre-existing cardiovascular disease increases the risk of radiation-induced heart disease. So if they're diabetic or hypertensive, they're more likely to develop it over time. Concomitant use of anthracycline. Even at lower radiation doses, those patients are higher risk to develop problems down the line. The younger age at time of radiation, active smoking, and inactivity are also associated with this. We're going to run through with this case. This is a patient with a hefty dose of radiation. Recently was changed to capecitabine. The capecitabine is actually a 5-FU derivative. It's an orally administered 5-FU. And she comes into clinic with my colleague with chest pains. A closer scan of her EF, low normal, maybe a little bit of hypokinesis in the RCA. So she's about 3 to 4 years out of radiation. She's young. Now she has stigmata of some mild disease within the LAD, and this is what we normally see. We see non-calcified and calcified plaque, usually in the left main LAD due to their anterior location. Her calcium score was at the 90th percentile for age, although it wasn't very high, but she was very young. There's no CAD in this patient. This is not truly what we see to explain this picture. So we see now an MRI the next day with a diffuse transmural scar in the RCA distribution. This is actually a capecitabine-induced cardiotoxicity that we see. So we talk about 5-FU agents causing vasospasm, and we think of chest discomfort as, not being that big of a deal, but we often see these, is that they spasm to the point that they infarct, and they infarct pretty bad. So keep that in the back of your mind. So 5-FU is not as benign as you may think. These patients have major infarctions. Now, switching gears, thrombocytopenia in cancer patients is a big problem. We're often asked, when do you say no to a TEE? It's near never, honestly. We looked at a 15-year review of our patients to look at rates of complications in patients who are thrombocytopenic. We had about 2,500 patients in this cohort. 814 patients were thrombocytopenic. Patients had, we had about 200 patients with a quarter of the patients had platelet counts less than 200. We looked at the indications, usually endocarditis and masses were the highest, and we looked at the rates of complications we had. And really 99.6% of the patients did well. Very, very rare incidence of oropharyngeal bleeding in our thrombocytopenic cohort. We had one major complication in a non-thrombocytopenic patient, unfortunately. So what this data drives us now in our thrombocytopenic patients, do we ever transfuse? Rarely, okay? Very, very rarely. In patients with platelets less than 20,000, we pause at times. We take it on a day-to-day basis and a case basis. Do I do TEEs on patients less than 10,000? Sure. Without platelet transfusion? Sure. But you just got to be super cautious. Do I let the fellows now do them? Yes. So oftentimes when we were in imaging and general fellowship, everyone halts and stops. Platelets are less than 50,000. If you do them gently and you position the patient correctly, you're not going to have as big of a problem. We've demonstrated that from our patient cohort. So take that with whatever you want, a grain of salt or add the whole shaker. Now, cancer patients present with other they present like any other patient. This is a first echo on a patient with breast cancer that came to us, an elderly lady with a restrictive cardiomyopathy, apical strain pattern. Her immunofixation assays for kappa and lambda were negative. She had PYP scan that was positive with a heart to contralateral lung ratio, and she had biopsy-proven TTR. Now, this is a different flavor, and this is what I see regularly at Anderson, and this is what you'll see on the boards for cardiac amyloidosis, the very thickened ventricles, the very thickened LV walls, small ventricles, pericardial effusions, pulmonary hypertension. patients. This is pretty much end-stage AL amyloidosis, and we proved that with a CMR in this patient. You get altered kinetics on TI scouts, you get diffuse LGE throughout the chambers. But is this where we need to be catching these patients? Definitely not. This is end-stage heart failure. This is not where we have room to improve. So the rule of Ford's on echocardiography, we always talk about increased wall thickness, small ventricles by atrial enlargement, and the reduced apical sparing GLS with the E prime, A prime, and S prime ratios being reduced. Now, I'm going to skip a little bit to the use of CMR in this patient population just for the sake of time. CMR has tremendous values based on tissue characteristic. It is high definition imaging for cardiac amyloidosis. Those of you in the CMR lab know that. You see very high elevations of T1 values both in AL and TTR in cardiac amyloidosis. And in addition to that, you see very high ECV elevations. Usually an ECV above 30% is a cutoff for halt and think, could there be amyloid or not, even in the absence of LGE. The higher the scar burden, the higher the LGE. We have good data to support that. The higher the T1 elevations do correlate with both systolic and diastolic dysfunction, along with ECV of itself being predictive of adverse outcomes. Patients who were previously treated or are currently undergoing treatment for AL or for amyloidosis who have a higher ECV are more likely to have poor outcomes and poorer survivals. So this is a picture, and myself and the myeloma team work very closely together. This is a patient who had myeloma, treated in remission, moved to Houston, got established with the myeloma team. Labs were fine. They got an echo and they called me. They said, you know, what do you think? It was read as normal, a little bit of sigmoid septum. By mass ratio, it was fine. Lateral E prime is 11, medial E prime is 7. Everything else looked okay, except for apical sparing pattern on the strain imaging. Should we do more or should we stop? We've seen this now time and time again. Even on CMR, we have normal wall thickness, we have normal structural findings, but when we go to tissue characteristics, we see this. The first sign we see in early AL amyloidosis is the loss of temporal nulling within the myocardium. So this is the first thing you see, followed by atrial and basal segment LGE. And so this patient, we had discussions between the myeloma and myself, and we went ahead and biopsied it, and it was AL amyloidosis. So now she went ahead and she got a transplantation. Despite her being on prior therapies, she went through the usual line of care with CyBorD. Now she underwent transplantation. She's doing well. The myeloma team, and over the past now 3 years, is a big proponent of diagnosing those early. We know that AL amyloidosis is a medical emergency. They order the CMRs before they send them for echo because we are seeing this time and time again where we can detect. The only way we detect it is by CMR. On echo, in early cases, strain may be the only thing that's abnormal, and we have cases where we have a completely normal strain, completely normal echo with AL amyloidosis. So am I saying every single myeloma patient needs a CMR? Not yet, but we might get to that point where the patients with high features of myeloma might start getting referred for CMR. So my practice is skyrocketing right now. So this is all I have for today. These are the areas that I'm working on. I'm dedicating a lot of research in novel imaging techniques in conjunction with the nuclear department, where we have a locally grown radio tracer that we're trying to target this immunocheckpoint inhibitor myocarditis to see if we can recognize them early. And vascular toxicity and immunotherapy is a new frontier that we're having to deal with. So I'm opening this to questions. I really thank you for your attention. I hope this was informative. Thank you. Go ahead, please. We have, we do the gray blood, we do the dark blood, but to tell you truthfully, the TI scout is a very, very early predictor. That's probably the first one we see. If we lose that temporal nulling where you cannot get the myocardium to go black, that's the first thing we start seeing, and then the LGE within the atrial walls tends to show up first. So we use it. Hi, Dr. Q.
Question. Those patients with immunotherapy myocarditis, you show them with a normal EF. What do they die of?
So very good question. So the cardiac complications, so it's a complicated answer to a simple question. The majority of these patients die of usually cardiovascular toxicities. They have arrhythmias. They often present on the first EKGs as maybe PR prolongation or AFib, and quickly they degenerate if untreated to VT-VF. And then there's the other spectrum where they're fine one day and then they tank their EF. If untreated, they have florid cardiogenic shock and they die. So that's why an early diagnosis within that field is really, really important. You don't see a normal EF with a troponin of like 2,000 normally, but we see that with ICI myocarditis quite frequently, and it's leaving us a little bit puzzled. We're starting to see that troponin I might be more predictive than troponin T within this patient population. I tends to be more predictive than T, but hopefully by the end of the year we'll have our data finalized and submitted. But usually in the cases with tissue diagnosed, the I tends to go higher than the T. Go ahead.
You mentioned the discordance between the CMR and the biopsy findings of the expert myocarditis. How frequent is the sampling bias in the sense that positive MRI and negative biopsy? In those scenarios,
Good question. They're usually negative early on. At least the first week, the initial data says if you delay a CMR by 4 days, you're going to have a higher sensitivity at detecting edema, elevation in T2 times, or even scarring. We're seeing that probably even after the 7th day, we start picking up the scar. The case I showed you, it took about 21 days to see the scar. They tend to be negative early on. And then that really complicates matter, right? So a tissue diagnosis is needed, and we biopsy them all, unfortunately, as this time stands. And that's why we're working on trying to find some novel biomarkers. PET isn't panning out. CMR to date hasn't panned out. We don't have CMR strain on our sequences. I don't know if it would add much. We're talking about adding it, but I don't know yet. Any other questions?